We are going to have a presentation by Sara Hughes, who's an advanced practice nurse here at MD Anderson. She's been working in cancer medicine in Texas Children's Hospital and at MD Anderson for 15 years. And she started working alongside Dr. Trent just as Gleevec was starting to become part of standard treatment and has stayed with GIST for 5 years. She's now part of the Palliative Care Systems Management Department as an inpatient practitioner and has extensive experience in issues surrounding diet and nutrition after surgery and is going to speak about coping with the new GI tract after surgery. So we need to welcome Sara.
I want to thank you very much for the opportunity to come and speak with you today. I guess part of the reason why I have experience with this is on a kind of personal note. I had gastric bypass surgery about a year and a couple of months ago, and so I don't fully understand, you know, having a cancer removed and that adjustment, but I do understand the adjustment of having what we're going to talk about, partial gastrectomies or full gastrectomies. So I think I wanted to share that with you so it helped kind of to validate or give me a little bit more credit when we start to talk about some of the different symptoms and some of the things that you may or may not encounter. The other thing I'd like to share too is I also have an autoimmune disorder. So I am treated with medications that are suppressing the immune system, like Gleevec or Sutent does as well. So there are some aspects in which I can identify with you. And I think that the key thing with working with this group of patients is that you have learned to live a new normal of a life. You can have a good quality of life with this tumor, with the treatment and the surgery that may be needed. And so I think that that's really important. You just have to redefine what your new normal is. But quality of life is there for you to have. So let's go ahead and get started on this. This talk is mainly going to deal with life after partial or total gastrectomies. Some of you will have surgeries that will involve the small intestines and large intestines, maybe even the pancreas and the liver. And so unfortunately, due to time constraints, I'm really just going to focus mainly on the partial or full gastrectomy. So just a little review. The stomach is the digestive organ that's connected between the esophagus and the small intestine. Food enters the stomach through the esophagus where it's broken down and then transferred to the small intestines where your nutrients are absorbed. The stomach's primary function is that of a reserve. It helps to initiate the digestive process and to release its contents gradually into the duodenum so that digestion in the small bowel is optimally performed. So you're lucky if your surgery involves your small intestines, you don't run into necessarily all the problems that with the nutrition absorption. So let's get started on this. Talk a little bit about post-operative care, and this is like immediate post-operative care. So you come, you have your surgery that following evening, that following night, couple of next days. This is what I'm talking about. Post-operative pain. You may or may not have it. I think you may be very surprised that pain is really not as big an issue as you maybe thought that it would be. But if pain is an issue, you need to be honest with your physicians and honest with your nurses. Nobody wins an Academy Award for, you know, trying to suck it up. Because once your pain is controlled, then you can focus on other things, which is getting up and moving. So pain medication is important. The other thing is because the abdomen has been worked on, you just naturally tend to want to guard it and protect it. So you want to make sure that you get up, you're standing up straight, and you start walking as soon as they give you permission to do that. So what happens when you cough or you have the hiccups or something like that? It can be kind of painful. So you want to make sure that you have a pillow that you can put up against your abdomen. Sometimes they give away teddy bears that have a hard back that you can put, and you so then when you cough, you have that support to help you. Another thing sometimes that you can have is an abdominal binder, which is just an adjustable kind of elastic thing that can connect with Velcro, and again, it just is giving you just that extra support. Again, you want to get up, get moving. You want to do your bathing. You naturally feel better after you've had a shower, so you want to make sure that you're keeping your incision site clean, and again, that you're up and moving. Now, yes, you're going to go slow, but things are going to get better. But the longer you wait, the harder it's going to be. So really, it's very important to get up and do your walking. Another reason for that is because you want to kind of prevent post-op infections. When you're sitting up in a chair or walking, you naturally have to breathe deeper. So that helps to prevent any kind of pneumonia that could happen. Again, they will instruct you on deep breathing and incentive spirometers. I don't know how many of you have had surgery and seen those. It is important. I know it seems silly to be blowing into this tube, but again, you want to get out of the hospital as soon as possible, so you have to play along, but it really does help. They'll go over your incision care, and if there's any tubes like drains, you will be educated on how to take care of that before you leave the hospital. And a lot of times you'll have to do demonstration back to the nurse before they will even give you the equipment to take home. Again, some of you may have ostomy, may end up with an ostomy, but not really necessarily with the gastrectomy that I'm talking about. But if there is ostomy care that needs to be done, again, you're going to be educated. I think the important thing, that you need to know is that, before surgery, really a lot of your questions are going to be answered, but sometimes you just don't know until you get there about what's going to happen. So when calling your doctor or nurse, this is after surgery, if you have temperature greater than 101, 3 or more episodes of nausea and vomiting, severe abdominal pain that's not helped with your pain medication. If you have no bowel movement for 3 days, please call your nurse. I can talk about constipation all day long, and we'll get to that slide, but you want to call your nurse. Do not get constipated. If you're dehydrated, you're not getting in enough fluids, if there's any problems with your incision site, redness, if it's warm to touch, if you have drainage that is not a color that it should be, or if it has a funny odor, please contact your nurse. And it's not Pat. You want to make sure that you call the surgical nurse. But of course, again, this is your new life. Your adjustment will depend on exactly what GI part of your GI tract is involved. Again, follow the instructions. I have to tell you, I unfortunately have had quite a few medical problems, and sometimes I just like to treat myself and not listen to doctors. This is the one surgeon that I listen to. It's the one doctor that I have followed every single thing that he has said. So it is important to listen to what your medical team tells you. And so with some of what you're thinking, you have to get a new outlook on what eating is and what food is. Some of you have already been treated with Gleevec and Sutent, and so appetite is already a problem before you have surgery. And so sometimes you have to step back and view exactly what is food. Food is fuel. So we know that when your protein levels and your nutrition level is high, you tolerate treatment better, you tolerate surgery better, and you feel better altogether. So it's important to, I'm not really hungry, I don't really want to eat, da-da-da-da-da, but you have to remember that your body needs it for fuel now. It's not just necessarily for enjoyment. Okay. So some of the effects that you can have after a partial gastrectomy or total gastrectomy, what we're going to talk about a lot today is your body's ability to absorb nutrients. You develop some intolerance. We're going to talk about dumping syndrome. We're going to talk about the fat is not digested like it used to be. Gastric stasis. We're also going to talk about lactose intolerance, and then some of the anemias that can be had after having surgery. Also metabolic bone disease, but good news is you don't really have to worry about that until about 10 years after surgery. So put that way back here. Dumping syndrome can I have a show of hands of who's had surgery, gastric partial? Okay. All right. So we do have a good number of people here. Anybody experience dumping syndrome? Okay. All right. Anybody find that fun? No, it's not fun. And, you know, again, it's one of these things that they try to educate you on, and sometimes you just have to learn the hard way. But what the dumping syndrome refers to is this sudden rise and then drop of your blood sugar levels, and in turn cause symptoms such as diarrhea, bloating, nausea, dizziness, weakness, sweating, and a rapid heartbeat. Yeah. Excuse me. So what happens is when you have the gastrectomy, it is either impaired the function of the valve between your stomach and intestines, or that valve has been removed. So without that, the sugar that you ingest flows directly into your intestines. So normally you have a regular stomach and you're sitting down and you have, say, you know, your dessert or your piece of pie. You know, it gets digested, body slowly dumps insulin in, processes, and everything's fine. Unfortunately, in the dumping syndrome, because your stomach is smaller or not even there, you don't have that slow, gradual release of the food. So it just is wham, and then the insulin shoots up and then shoots back down. So, and it can happen pretty rapidly. It's kind of impressive. It can happen within 15 or 30 minutes of eating. And so, again, it really creates a bad cycle of the high-low, high-low. And I don't see the gentleman here. The first time I ever saw this syndrome, it was a gentleman who had come down to have a regular follow-up visit and had his CT scans, and then went down to the cafeteria and ate some stuff that he shouldn't have. And when he came up to see us, he had come by himself. I think it was like one of the first times his wife had let him come by himself. And we were talking, and then 5 minutes into the conversation, he didn't know where he was. He was sweating, his pulse, his blood pressure dropped. We had to put him on the stretcher and take him to the emergency room. So it can be really scary. And so then we made fun of him every time he came in after that. And I had to call his wife, and so he was never allowed to come by himself again. So two parts of your dumping syndrome, like I was talking about. You can have the early dumping, which occurs about 15 to 30 minutes after ingesting the meal, and is evident by diarrhea, really full bloating feeling, abdominal cramps, and vomiting. So every once in a while I have to try to remind myself that I've had surgery that affects how you absorb things. And so about 2 months ago at Gringo's, I decided, why not have a margarita? I've earned it. Totally forgetting about the sugar content. And my parents just got a big kick out of it. They just thought that was funny. But so don't do this in a Mexican restaurant. So sorry, no margaritas. But you can also have late dumping too. So sometimes you think you've gotten away with having that particular food you shouldn't have had, and you go, wow, okay, good, this is something I can tolerate. But you can have it even up to 2 to 3 hours after eating, and again, it results in the weakness, sweating, nausea, and anxiety, which is always fun when you have to try to explain to people around you what's going on. So really, what do we want to do? We want to prevent the dumping syndrome. This can be done by eating 6 small meals a day. It's a little different in the setting for y'all as opposed to the gastric bypass surgery. They don't want 6 small meals a day, they just want 3. But in your situation, you know, you're still getting nutrition, you're still eating your, needing your food, needing to maintain your weight. So you're not looking for weight loss. So again, 6 small meals through the day. This is also a good thing too if you're having problems just with your appetite in general. It's hard to sit down and eat 3 meals a day if you're gotten out of the habit of doing that. So what I do is encourage patients, and what I mean by small meals is, literally some cheese and crackers or peanut butter and crackers or some fruit, but you actually have permission to be grazing or nibbling throughout the day. You want to eat slowly, and you want to chew your food thoroughly. And it's really surprising when you have to sit down and eat slowly, how long that can take. So you might want to practice these things or put them into trial even before you have surgery. They recommend, I think, like chewing your bite 30 times before swallowing. You're going to be making a lot of adjustments, so if you can do anything beforehand to kind of get you used to what your lifestyle is going to be afterwards, it's really beneficial. You want to sit upright, which I know sounds kind of funny, but you don't want to be, eating in bed or in the recliner. You need to be sitting upright at the table. Again, it's just helping with that swallowing. You want to eat meals that contain protein and are high in fiber. Now, the reason for this is because, remember, you have a small reserve, so you have to eat what's important. So the most important thing for you to eat is protein. And then after that comes the high fiber. Unfortunately, carbohydrates and sugars and all of that really are the last thing that you want to eat, because remember, again, food is fuel. Another thing that you want to do is limit the fluid consumption while eating meals. A good trick is to not drink anything 30 minutes before you eat and to not drink anything 30 minutes after you eat, because it gives you more room and it's going to help less with that kind of bloating feeling that you can have afterwards. Again, you want to avoid things that are high in sugar content, soft drinks, the carbonation, not a good idea, candy bars, and unfortunately many of the nutritional drinks that you get while you're in the hospital, things like Ensure and Boost. Before you have surgery, we're encouraging you to get those empty calories and using, Carnation Instant Breakfast and, permission to add ice cream to anything you want and things like that. So unfortunately, this part changes, again, because of the high sugar content. So you have to look for some extra sources of protein, and there are protein shakes that are available, or protein supplements that are available that don't have the sugar content. So those are a good supplement when we're talking about doing the 6 small meals a day. So that can be used as a substitute. Okay. So you're going to have problems, again, with things that are high in fat. So fried foods, unfortunately, don't work well in this situation. You can occasionally get away with them, but you really are going to have to modify your diet when it comes to fat. Sometimes you end up needing to do an enzyme replacement to help with that, but that's really rare. I think just making sure that you're focused on good nutritional habits, you should do fine with this. They're going to get us eating healthy one way or the other. Another problem sometimes after surgery is gastric stasis, and what that has to do with the muscle, the way the muscle in the stomach contracts. And so sometimes that can hamper the digestive process, making it slower because you don't have as much of the muscle content that you had before surgery. And it takes sometimes your stomach a little longer to empty properly. So if that is a problem, what you're going to see is bloating and discomfort and fullness that may last hours after you eat. So, you need to always kind of be aware of what's going on, and a good clue of when to talk to your doctor about whether something is a problem is when, after you know what to do, it still hasn't resolved. And if it continues to be a problem, I mean, if you have one day of where this is a problem, no, you don't necessarily want to call your doctor, but if there's a pattern, especially if you have vomiting and there's undigested food that's still there that you have eaten several hours before, it's really a pleasant topic after lunch. But nurses, we can talk about gross stuff all the time. Lactose intolerance, which is interesting. Even, there's a high percentage of people that are lactose intolerant even before surgery, but you become lactose intolerant even after surgery if you weren't before, and it just has to do with the lack of the enzyme that you have. Again, there's abdominal cramping, bloating, diarrhea, bad gas. So really not pleasant. You can't get away with not claiming it, I guess. I have brothers, so. You just have to know that you need to decrease or avoid lactose as much as possible. But this can improve over time. So, little amounts are okay, but I just wouldn't, again, have, a lot of dairy products as your first choice when you sit down for a meal. All right, I think one of the big concerns that you may have, which is one of the concerns that you may already be dealing with, and that is anemia. And in the setting of the gastrointestinal stromal tumor, you already are at high risk for developing anemia of what's called chronic illness or chronic disease. It just means that patients that have just cancer in general, as well as chronic illnesses, already have a problem with their red blood cells. So a lot of you may already have anemia that's being addressed either by Aranesp injections, and some of you may have needed blood transfusions in the past. It's important for you to know that we do monitor your red blood cells closely. You will have you should have lab work done every time you're seeing the physician. You have what's done as a complete blood count, which shows your white blood cells, your red blood cells, and your platelets. And so the red blood cells are what are responsible for taking oxygen throughout your body. So that's what we're looking for when we're talking about anemia. The red blood cell is then further broken down, and so we can actually look at the interpretation and know almost with what kind of anemia that we are dealing with. And again, it's hard because the symptoms, some of the symptoms of anemia are also some of the symptoms that you have with the side effect of your treatment. So again, it's important to talk to your physician about the concerns that you have. Somebody that is anemic that doesn't have, just in the setting of just having plain anemia, will have fatigue, but a lot of you are already battling fatigue just due to treatment. So you want to look for something that's abnormal. Okay, so the consequences of anemia can be severe. Your heart really likes to have enough blood to pump around the body, doesn't like to have to work too hard. So this is, again, important for why you need to do your follow-up blood work. It can present sometimes as a late complication in gastric resection, but unfortunately in your case, anemia is probably already presented. The different types we're going to talk about is B12, folate, folic acid, and iron deficiency. All right, vitamin B12 malabsorption occurs when a protein known as the extrinsic factor is either not produced by the stomach or is not produced by the stomach or when the proximal stomach is resected. The absence of the intrinsic factor leads to poor absorption of vitamin B12. So under normal circumstances, the intrinsic factor binds to vitamin B12 and assists in the absorption of the vitamin in the lower portion of the small bowel. And so because your stomach is not there, this factor is not produced, then you cannot absorb B12 normally through a regular diet. B12 can have some symptoms, again, like fatigue, chills, but mostly what we think about is if you're having problems with numbness or tingling in your extremities. Also some dizziness or some other neurological symptoms. So the good news is that B12 can be given to you a couple of different ways. One is injection. The other is orally, and it's sublingual. It's better absorbed that way as opposed to swallowing a whole tablet. There's also a nasal spray too, because I know that you get to a point where you're on so many pills that if you have to take one more pill, you're just going to scream. So again, very different ways to deliver the B12, and again, important. It's important to know that it can be resolved. Just because you have a B12 deficiency once doesn't mean that that's something that you are going to have for a lifetime. It again can be treated. Folate or folic acid is a vitamin that's found in an abundance of food. Your body has a reserve for about 4 months. So folic acid, again, it's an important vitamin that just helps with the production of the red blood cells. And it too can be easily taken either in a really good multivitamin or by itself. So a little thing about vitamins. Pat and I would always get nervous when people would come in with a list of all these super duper vitamins, super duper supplements. You have to really be careful about those because one, they're not tested by the FDA. So they don't necessarily have to list all the ingredients that they have in them. Another thing is we don't know how that interferes with your treatment. It could make the Gleevec or the Sutent or whatever medication you're taking less effective or more effective. And I know more effective sounds good, but not really, not in this case. So if you hear a lot about, I guess, noni juice is another one that we hear about and things like that. And I want you to know there is a time and a place for alternative therapies. And I think that time and place is when you're not on active treatment. But really you need to be honest with your physician and your nurse about exactly what all medications that you're taking. Because sometimes if we're looking at lab work, wondering what's going on, sometimes can really be directly linked to a supplement that you're taking. The story that I have is I worked bone marrow transplant for several years, and I had a lady that we actually worked up for a bone marrow transplant that we were getting ready to admit, and she did not tell us about all the medication she was taking, and one of them was St. John's wort. So when she stopped taking that medication, her marrow resolved, so she did not end up needing a bone marrow transplant. So not a scare tactic, but maybe it is. So really just be honest with us because we want you to be as healthy as possible through all of this, because you don't have a lot of control over what's going on, and this is one of the most proactive groups of patients that I've ever worked with. So just be careful with your proactivity, and again, any questions, feel free to ask the great Dr. Trent. He will know. The next one is your iron deficiency. So this one's probably more commonly known. And so again, it has to do with the fact that the removal of the stomach leads to a marked decrease of the production of the gastric acid. And it's this acid that's necessary to convert the dietary iron to a form that can be absorbed more readily. Iron is stored in your bone marrow where red blood cells are produced. So again, you almost have another strike against you because of the way that your therapy, the Gleevec Sutent, works, is that it does do immunosuppressive activity. So you've already got a strike against you with the red blood cells. So iron deficiency is something that we see very common. Again, an oral supplement can be taken, but let your physician tell you when to do that, because you may have a lot more reserve in your marrow. Iron is not fun to take. I know there's probably a lot of ladies out there that have had to take it. You can't take the slow FE or the time released. Because of the way it's coded and the way that you digest things, it just doesn't work as well. So it's the iron tablets. They can cause constipation, they can cause nausea, they can cause vomiting, but it's a very important pill to take. I think what is interesting is vitamin C will help with the iron absorption. So if you can get away with it, taking your iron with orange juice, you end up getting a little better absorption. Okay, metabolic bone disease. Again, you're not having to worry about this until 10 years after your surgery, or that's what the literature said. One of the things that can happen is osteoporosis or osteopenia, and it develops as a result of the poor calcium absorption. Even under normal circumstances, calcium absorption is rather difficult because you lose a lot of it when you have bowel movements. And again, following surgery, your absorption is even less effective because of the rapid emptying of your stomach. So calcium also is another one of those things that needs to bind to fat in order to be better absorbed. So if you're on a low-fat diet, Again, you're not taking in the dietary or the dairy that we were talking about earlier. Calcium can become a problem. But again, before you start to take calcium, over the counter on your own, you want to discuss this with your physician, because a lot of times you have to take vitamin D with the calcium in order to have even better absorption. But another thing that we talk about sometimes in palliative care is just getting good sunshine too can help that. But wear your sunscreen. All right, another issue that may or may not happen, and really I think it's more that it doesn't happen than it does happen, which is nausea and vomiting. Nobody likes to vomit. Nobody likes that. I haven't met anybody that does. And so what you want to do again is to prevent that. We've talked about this before. It's your small meals throughout the day. And you have to realize, again, you're not going to be able to eat as much as you could. So sometimes your eyes still are bigger than your stomach, but you are going to learn what triggers you, what doesn't trigger you, what food works for you, what food doesn't work for you. Again, we talked about you want to drink your fluid prior, 30 minutes to an hour, because you don't want liquid competing with solid, because somebody's going to lose. It's usually you. So you want to also kind of keep a journal too, again, knowing what is going to set off things and what's not going to set off things. And again, if the nausea and vomiting is really becoming a problem, then you do need to inform your team, because it may be that we need to help you with medication, Zofran, or another medication called Reglan. All right, diarrhea. Woo. So it was really funny. I really thought this was going to be a bigger problem, diarrhea, than it was anything else. But no, it turns out really constipation is a bigger problem. And you'd be surprised. Constipation is just a huge problem, period. And what we mean by diarrhea is we mean watery stools, okay? Nothing formed. Soft is good. We like soft. But diarrhea is really liquidy. It has nothing formed in it. So again, we talked about you want to try to eat, your meals. You want to make sure that, if diarrhea is a problem, then what you want to do is to make sure that you eat your food actually before you drink your liquid. Again, because of the competition, eating the food, getting the fiber gives you bulk, and so that helps to kind of prevent some of the diarrhea. You also have to look at the medication too. With the Gleevec, Sutent, some of these other medications, diarrhea is already a problem. So we really don't want to, add something onto that. So if it is a problem, again, you talk to the physician. When we work on, a schedule, seeing what triggers it, what we can do, and then to see if medication is necessary. Diarrhea can be a big problem. It can lead to dehydration as well as electrolyte imbalance. It can buy you an admission to the hospital. All right, constipation. So in working in palliative care, no matter how much time I have or how little time I have with the patient, you get the top 5 questions. One is your pain, one is your activity level, and the other time is when is the last time you had a good poop. So it gets you paranoid pretty quick. So as a department, we sit around and discuss and make sure that everybody's on track. So if you're having a bad day, somebody may ask you, when was your last bowel movement? So constipation can be related, again, to many things. Medication, inactivity, as well as your dietary changes and your dietary supplements. We encourage you to take the iron, but the big part of that is constipation. And then we get you to take calcium, and a big part of that is constipation. And then we get you to do the constipation. And so then we tell you to increase your fluid intake. But we've also told you need to eat 6 small meals a day, and you need to make sure that you don't drink liquid 30 minutes before you eat or 30 minutes after you eat. So this can really become a full-time job. So it is really good to, get your system down and get to know your body. One of the things that you can do, which is interesting, hot fluids, hot tea, hot coffee, I think some of y'all may know that, can help to stimulate for a bowel movement. Increasing your fiber intake is important. Now that's kind of hard to do when you've got a limited food that you can intake. So sometimes you can get the ones over the counter, the Benefiber and things like that, to add to your water. So looking for different ways to get fiber is important. And exercise, wow, yay, exercise. So that, again, because of the inactivity, your bowels will get lazy. So exercise is good for not only constipation but fatigue. So we can't get away from exercising, and you're not going to be able to get away from a healthy diet. Which I always thought exercise was kind of funny, to get rid of your fatigue, because you're fatigued, so how do you start exercising? But you just have to do it, and you have to do a little bit at a time. And we're not talking marathons. I mean, if you're running marathons, that's great. We're talking about walking 10 minutes a day, 15 minutes a day, 20 minutes a day, building up some sort of routine. It's not only good for the fatigue, constipation, it's just good for your mindset. Because, you know, you want to lead as normal a life as possible. So exercise needs to be a part of that. There are medications that help, laxatives over the counter, but you have to remember that, again, some of your constipation may be related to decreased fiber intake. So again, be careful with the laxative intake because you could set yourself up for diarrhea. If you do need medication to help with constipation, you have to know that everybody's a little bit different. So it may take you 2 pills of Senecot, for example, in order for you to have a bowel movement every day, and it may take somebody 1 every other day. But we do like for you to try to have a bowel movement every day. Again, if constipation becomes a problem, inform your team. Don't be embarrassed about it. We have a nurse here, a nurse practitioner, who that's her whole job. She's the bowel management nurse. Really cannot imagine anything more unpleasant. But so we do have resources here at MD Anderson. You know, please don't try enemas and all these other kind of things to help get you going, because you really can do more damage than good. Okay, another problem is early satiety, which means you get full fast. And some of that happens, one, because you're out of the habit of eating. So we talked about that earlier. You have to get back into the habit of eating. So the small meals, again, is where this becomes very important, even if you're not having surgery and you know your appetite's a problem or feeling full fast. So again, small meals. Again, remember that food is fuel, so you have to sit down sometimes and just do it. And the other thing that can be a problem is constipation. So if you're really full, you don't have room to for your stomach in order for it to expand. Okay, another thing that's pretty rare that you have problems with, but I did want to bring it up, are adhesions and then intestinal blockage. So what happens is after surgery, you have scar tissue that develops, and it's just your body's way of healing itself. But sometimes the adhesions can become a problem and even restrict the passage of food through the gut. And then sometimes the GI tract itself can become obstructed, and this becomes a medical emergency. So signs of a bowel obstruction would be constipation, not able to pass any gas, severe nausea and vomiting, sometimes even projectile abdominal pain. And it usually comes on pretty suddenly, and it is an emergency. You do need to be evaluated. Treatment for this is either medical or surgical. Surgically, they can go in sometimes and resect the blockage, or other times medically we'll bring patients in, make sure that they're really well hydrated and see if we can't get things to move along without any surgical intervention. Because every time you have surgery, you're going to develop more adhesions, which is going to maybe put you at higher risk for developing problems with blockage and more adhesions. These can cause chronic pain as well as some dysfunction. Again, it's formed after any trauma to the tissue, so there's not really anything you can do to prevent the adhesions. There's not really anything your surgeon can do to prevent the adhesions. The pain will tend to last longer than the original trauma, meaning so you've had surgery, you feel like you've recovered, but you know, weeks, months down the road, you get a little twinge, you're not sure what it is. Sometimes it can just be that extra scar tissue. And I'm getting close to done. So, things to remember. There is life after surgery, and life is good. Again, this is going to become your normal way of living. I think what's interesting that's not addressed sometimes is the emotional part of eating. I mean, we gather for family functions, we gather with friends, and the big thing is to go and eat. And there's a lot of social enjoyment that you get out of that, but unfortunately, due to what you have to change your lifestyle to, you almost don't want to participate in that. And it's hard. But what you need to know is, again, you can. You develop your habits. You have your friends that are very supportive, but it's hard there in the beginning because you don't realize just how much of our time is spent with eating and food. Don't watch the Food Network. I stayed with my parents after surgery, and they're so supportive, and they watched the Food Network the whole time I was there. I was like, you gotta be kidding me. But again, you will get past that, but I don't want to undermine the emotional journey that you do go through. I don't think we're good at addressing that. Even the emotional journey you go through with having a diagnosis of a gastrointestinal stromal tumor. Y'all all know that this is a very rare disease. And so you find comfort in numbers. So things like this are very good to participate in because you can find people that know what you're going through. And that can be one of the biggest helps. That can be more helpful than any medication that we can give you. So again, you're not alone in this process. No question is too strange. And you have great resources here at MD Anderson. We have dietitians, you have full access to your surgery, your surgeon and their team, and again, the bowel management nurse. And so I just want you to know that we don't want you to have this surgery, which is very life-changing, and then be on your own. So we're here for every step of that process. And these are my resources that I used. I got a lot of information off of your website, so very good website to use. All right, thank you.